I want to thank the organizers to have invited me to this meeting, and I'm very proud to be there with you, and I really want to thank you. And I thank you, all of you, to be there so early to listen to me. So we are going to begin this meeting with the very young patients that have a cancer during the first year of life. And as I have only half an hour, it's very complicated to describe everything. So I choose to show you the epidemiology and the specific things related to these solid tumors, and I will emphasize my speech, on the fact that young children have specific toxicities that have been to be taken into account to manage them. And then I will end with the specificity of neuroblastoma in the first year of age. So, solid tumors of the first year of life have a major care complexity because of specific clinical and biological characteristics of the tumors at this age, but also mainly because of anatomic constraints. You have a very small baby and sometimes huge tumors, and it's complicated to be managed. In addition, these patients have an immature metabolism, and this leads to major chemotherapy toxicity we have to take into account to manage their treatment. And the surgical approach is very complex during the first months of life and even during the first year of life. In addition, these patients are very young, and we have to take into account the long-term sequelae and especially the radiotherapy sequelae in the treatment approach. I won't say anything more in my talk, so I wanted just to say that we have developed specific radiotherapy management for these very young patients, for example, with brachytherapy in pelvic rhabdomyosarcoma to avoid long-term sequelae. So to manage these patients, we need expertise and we need multidisciplinary management. You know that the management of solid tumors need to have a multidisciplinary approach with oncologists, radiologists, radiotherapists, surgeons around the table. But in these very young children, you need much more people. In this, in the SEER evaluation, it has been stated that the incidence of tumors during the first year of life was 234 patients per million of children less than 1 year. The main diagnosis is leukemia, but just behind you have neuroblastoma and the other solid tumors, CNS tumors with specific tumors at this age, with coral plexus tumors and astrocytoma, sorry for the mistake, and adrenal tumors. Retinoblastoma is also a very frequent tumor displayed at this age, and of course renal tumors with specific tumors at this age. There are very few, in fact, environmental risk factors that have been really identified, such as alcohol and smoking during pregnancy, and not much more to risk factors identified. But there is a very genetic predisposition has to be identified. At the moment, it's supposed to be around 10%, but maybe underestimated. You have, of course, the Lee-Froehlich syndrome, which is a P53 mutation that leads to rhabdomyosarcoma that can occur very early in the life, and leukemia. PTEN abnormalities with leukemia and neuroblastoma, of course, NF1 with glioma, SMARCB1 or INI1 mutation with rhabdoid tumors, DICER1 with neuroblastoma, and SUFU that we have demonstrated to be linked to a high risk of medulloblastoma. Cancer in children of less than 1 year is an immediate danger. But in general, the tumor of this age have good prognosis, except neonatal leukemia and rhabdoid tumors. You see on this slide a patient with a localized tumor that was treated with surgery and chemotherapy and had a huge metastatic relapse and eventually died. Clearly, rhabdoid tumors have a very poor prognosis in spite of intensive treatment. But except these specific tumors, most of the tumors have a good prognosis. So the issue when we are taking care of these patients is to avoid not to harm, primum non nocere. And in fact, cancer is only 1% of the cause of death in children less than 1 year, which is not a lot. There are many other causes of death. So the problem for us as pediatric oncology is to try to manage these patients in avoiding toxicity and trying to do the less we can do to cure them. In this very recent publication of the 13 registries in the SEER, there were 36,337 patients from 0 to 19 years. And they worked to identify the risk factors for early death within the first months of diagnosis. 555 patients died during the first month of diagnosis, which represents 7.5% of the total deaths. And in this study, the multivariate analysis displayed that age less than 1 year were the major risk factors to have an early death, which show you that it's very important to have a very cautious management of these patients. Sorry. Here you can have an idea of the different causes of cancer in general and during the first year of life. If you look at, you had around 35,000 patients. More than half had hematological malignancies, and the other CNS tumors represented 6,000 patients, and solid tumors 14,000 patients. In the first year of life, you had 559 patients with hematological malignancies, 379 CNS tumors, and 1,710 patients. Among them, so these patients less than 1 year represented 7.4% of the patients. Among the early deaths, you see that patients that were less than 1 year represented 24.9% of these deaths. And it was, the over risk was present both in hematologic malignancies, CNS tumors, and solid tumors. In the neonatal solid tumors registry in France, we identified between 2000 and 2009 285 patients between 0 and 29 days at diagnosis. More than half had an antenatal diagnosis. They had very specific clinical and biological characteristics, And the conclusion of this study was that they needed a multidisciplinary management with obstetricians, neonatologists, biologists, radiologists, surgeons, psychologists, and pediatric oncologists. Psychologists are really needed since having a child with a very young child with a cancer during the first years of her life is a real major problem for the family and for the parents, and it needs to be managed correctly. The sex ratio of this population was 1, but there were more girls with germ cell tumors. And as you see, the 5-year overall survival of the whole population was good, 83%. 47 patients died, and 15 died because of surgical complications. And this shows you how complicated is the management of the surgery of these patients. And we have to be very cautious on the indication of such treatments. In addition, what was underlined by this study is the presence of congenital abnormalities, malformative syndrome in 8 patients, and genetic disorders in 6. You have here the different diagnoses. Half of the patients had neuroblastoma, 10% have brain tumors, soft tissue sarcoma represented 8.4%, 1/3 was germ cell tumors, and you see that hepatoblastoma, renal tumors, and retinoblastoma were less frequent. On this panel, you can see the good prognosis of neuroblastoma at this age, of retinoblastoma, of course, and of germ cell tumors and hepatoblastoma. Brain tumors have a much less good prognosis, mainly because of a specific diagnosis at this age, and for example, rhabdoid tumors. And for renal tumors, it's the same problem with the occurrence of renal rhabdoid tumors with a very poor prognosis. To illustrate the fact that we need, the first aim is not to harm, I wanted to tell you about this story. Estelle was a 2-month baby that was diagnosed for abdominal mass at the ultrasonography, and she had a CT scan. And you see on this slide the renal tumor, which is not very big and looks very, very easy to be operated. She was transferred to my institution and had a very rapid clinical impairment. And in fact, she had consciousness troubles, and she was had a very poor clinical status when she arrived. At that time, we performed a biological evaluation and found a major hypercalcemia and a major renal impairment that explained this poor clinical status. She was transferred to ICU and managed for these metabolism problems. And in fact, the surgery could be performed, and the tumor was a nephroplastic lymphoma. When we saw this girl with this very poor clinical status and with these metabolism disorders, we saw that she had a rhabdoid tumor, because it's often linked with hypercalcemia. And fortunately, the diagnosis was different. But this girl could have died of a very good prognosis tumor if the metabolism problems have not been correctly managed. So it shows you that even with a good prognosis tumor, you can have these small children that are going to die because they are not correctly managed. And probably if time is a real concern, and they need to be transferred in an express center to be managed. The other point is the management of the chemotherapy. You have on this curve the ratio between weight and body area. And it shows you that when you are in the first months of life, when you administered 1.5 milligram per meter square, you will administer 8.8 microgram per kilogram. But when you are 10 and you do the same thing, it's equivalent to 5 microgram per kilogram. So just because of the baby constitution, you have a major difference in terms of dose. It's the reason why the doses for patients between 0 and 1 year are calculated on the weight and not on the body area. And you have to add on that point that you have metabolism, a different metabolism with different hepatic metabolism, a different renal metabolism that will induce additional toxicity of chemotherapy. And it's the reason why we define chemotherapy doses calculation according to the age, with decreased doses of 50% in patients with between 1 month and 3 months or weight below 5 kilos, and we don't recommend to use doxorubicin and ifosfamide at this age. Between 3 and 6 months or weight less than 8 kilograms, those are reported to the weight and decrease only of 1/3. And you can progressively increase the subsequent courses according to the toxicity you observed. And again, ifosfamide should be avoided if possible. And between 6 and 12 months, you can have full weight-based doses. But of course, you adapt the doses you administer to the toxicity you have observed to on the previous courses. An additional point is the risk of errors. Even tenfold doses are usually administered in a pediatric department. So it's very difficult to see that there is a problem for the nurse, to see that there is an error in the dose that is administered. And we know that in this population, there is a major risk of errors. It's the reason why we installed a double check at each step of prescription. Doses prescription with a senior supervision to be sure that the right dose. Chemotherapy, 2 pharmacists controlled at the chemotherapy production, and again, a double check for the chemotherapy administration. And it's a way to avoid doses error that are generally dramatic at this age. And actinomycin, which is quite a safe dose, usually with no major toxicity, can be a drama if you use it with an error at this age. And it's very easy to administer tenfold the dose. And at that time, the patient will die. In addition, we have developed as a method to try to adapt doses, chemotherapy doses to the weight and to the age. As you know, we are using in the Cypen group, and we have defined in my institution the way to manage IV Busulvex. And we have worked to define with pharmacokinetic the right dose to target the right AUC. And you see on this slide that it's easy to be in the target AUC when you have a weight that is more than 9 kilos. But here, the range is much larger. And it's the reason why the EMA requested to better characterize pharmacokinetic in children lower than 9 kilos to have a better adaptation. And for busulfan, it's quite easy, since you can administer your first dose, then have a pharmacokinetic, and then adapt the doses to the results of the first pharmacokinetics to really trigger the AUC you wish to have. So you can use pharmacokinetics for young children, for Busselton diseases. During the course, for one patient, you have this pharmacokinetics and then dose adaptation. For melphalan, you can have a dose test, then the pharmacokinetics, and you will define then the dose that will be administered 1 week later. For carboplatin, you can also manage pharmacokinetics to target a defined AUC. It is what is currently done for high-dose chemotherapy, but you can also do it in very young children when you are concerned by the possible toxicity and to adapt doses in a more usual setting. Now I'm going to focus my talk on neuroblastoma of the first year of age. As you see, neuroblastoma is a very young children disease. You can see the frequency of neuroblastoma according to the age, with this very huge peak before 1 year. And I remind you that we are classifying patients with neuroblastoma according to a high energy classification, and with localized tumors, L1, and with no surgical risk factors that can be operated, stage L2 with image risk factors that link to treatment before surgery, metastatic disease, and the special metastatic disease that is related to young patients with metastatic disease confined to skin, liver, and or bone marrow. Just this to show you the frequency of NMIC amplification, which is a major prognosis factor in neuroblastoma, and that link to intensified treatment. And you can see that even if NMIC amplification is mainly observed in patients between 1 year and 2 years and a half, you can have NMIC amplification before, and this has to be taken into account in the management of the patients. This slide to summarize the LINUS protocol during we are using in the CIAPN group. Maybe no. Don't. That's right. So no problem. Patients. The first point in the patients that are less than 1 year is to know what is the biology of the tumor. There is no NMIC amplification. The question will be, they have a primary tumor that has no image risk factors and surgery. To L1 patients with no NMIC amplification, they will have surgery. Then patients that have either a big tumor or a metastatic tumor will be treated to different groups I'm going to describe later. If patients have an NMIC amplification, patients that have a small tumor, L1 and NSS1, will have a specific treatment I will tell you about later. And the other ones are treated according to the high-risk protocol, using chemotherapy, surgery, high-dose chemotherapy, and maintenance treatment with immunotherapy. Biology is a major factor. You have seen that in these young patients, NMIC is a major factor to treat the patients, but we also use the chromosomic profile to treat the patients. And the Cyropen team with Gudrun Schleiermacher has shown that the evaluation with CGH of the tumor could define two groups: patients with numerical abnormalities, which means you have one whole chromosome in addition or in deleted. And these numerical abnormalities have a good prognosis, as you can see there. Or if you have segmental abnormalities, then you have a poorer prognosis. And this is currently used in the Linus protocol, in the Cyropen protocol, to classify patients and treat them differently. And specifically for localized tumor L2. How do we manage these patients? These patients have a localized tumor. Surgery is not possible because of image risk-defined factors. They have life-threatening symptoms that have to be treated. They have no life-threatening symptoms. Then we are currently randomizing either observation or a slight chemotherapy to induce regression of the tumor, and perform surgery only if you have no more image-defined risk factors. So the question is, can we just follow these patients to see if the tumor is going to spontaneously regress with no problem? So again, we don't want to harm. We want to have the lower treatment to cure these patients. On the other side, if you have, of course, life-threatening symptoms, you have to treat them, and you will treat them with VP16 and carboplatin until these symptoms are regressing. And if you cannot obtain this objective, then you move to CADO, which is cyclophosphamide, adriamycin, and vincristine. If you have biological abnormalities with segmental chromosomic aberration, then we treat these patients, but again, to obtain the possibility to perform surgical resection. And I will give you some examples. The first example is the Dumble neuroblastoma, which is an emergency. These Dumble neuroblastoma are more frequent during the first year of life. They are more frequent in thoracic primary tumors, and the objective is to avoid neuro and orthopedic sequelae with treating them with VP16 and carboplatin, and in addition with corticosteroid. Gani. Sorry. You have this example. It's okay. You have these images of scan and MRI. And you have the MIBG scan here that shows that you have the thoracic tumor and nothing else. And you have this very big tumor involving the spinal cord. This patient was treated with 2 VP carbo that induced this major reduction, and he had surgery at that time, and he is alive without sequelae, which means that treating these patients with chemotherapy and corticosteroids and allowed to cure him and avoiding long-term sequelae. The other question is the metastatic tumors, and again the question is, are there symptoms or not, treated differently according to the biology. And here you have these images of metastatic neuroblastoma and with the nodules, subcutaneous nodules. These patients have a very good prognosis, but they can be very difficult to manage initially. You have here the huge hepatomegaly, and after IV injections, you cannot see the nodules, and this is really typical of metastatic neuroblastoma. And this is the images in the MIBG scan. And these patients can have a very difficult, we can have some problems with their management. And this is a patient with this metastatic neuroblastoma with a rapid disease progression. She was managed in ICU because of major respiratory distress syndrome. And she received 2 courses of VP16 carboplatin with a major toxicity. But just after these 2 courses, she had a disease regression and she had a delayed surgery. At that time, we identified the favorable biology, and she's alive with no sequelae, with only 2 courses of VP16 of carboplatin. But of course, she needed surgery of discharge to allow the management at the very acute phase. So it means that we just have to do the less we can to allow the disease to regress and then to correctly manage them. I think that time is running. You have the end of the treatment for patients with metastatic disease. We have a heavier treatment, but again, the objective is to cure them without too much treatment, and we can cure them with around 90% event-free survival without high-dose chemotherapy. The question of the L1, ENS1 is complicated, very few patients, and we have a mixed care with 6 courses of chemotherapy, surgery, local radiotherapy, and maintenance treatment. So to conclude my talk, what we can say is that solid tumors are frequent during the first year of life. Most of them are neuroblastoma. They have a good prognosis except rhabdoid tumors. And they have a high risk of early death related to surgical complications and related to chemotherapy. So the first goal is to really evaluate the aggressivity of the tumor and to adapt the treatment to this aggressivity, to have an expertise on multidisciplinary management to allow these patients to be cured. So I want to thank you, and this is my institution, and I see the Eiffel Tower from my office, so I wanted to share that with you. Thank you very much.
Спасибо большое. Вопросы, комментарии по поводу доклада? У нас есть 1-2 минуты на это. Качанов Денис Юрьевич, заведующий отделением клинической онкологии, доктор медицинских наук.
Я прежде всего хотел бы поблагодарить доктора Волто-Коане за замечательный доклад. И хотел бы тоже сказать, что наш собственный опыт показывает, что это очень особая категория пациентов, которая требует обязательного мультидисциплинарного подхода. И я думаю, что это та категория пациентов, которая всегда должна, и лечение которых должно производиться в центрах, которые могут обеспечить все этапы медицинской помощи, начиная от выхаживания в условиях отделения реанимации до очень тщательного, взвешенного подхода в отношении обсуждения выполнения хирургических вмешательств, проведения химиотерапии, поскольку действительно за последние 5 лет мы накопили опыт лечения более 350 детей раннего возраста с солидными опухолями и видим, что одна из основных проблем заключается в возможности побочных эффектов и химиотерапии, и хирургического лечения, поэтому мультидисциплинарный подход критически важен, и тот посыл, который Доминик Волто-Коане пытается нам донести, что мы должны не навредить этим пациентам, имеющим зачастую достаточно хороший прогноз, но при этом этот прогноз может быть скомпрометирован необоснованно агрессивным лечением, с одной стороны. И с другой стороны, действительно есть определенные подгруппы пациентов, например, больные с злокачественными рhabdoидными опухолями, которые требуют критически интенсивного лечения, очень агрессивной химиотерапии, агрессивного хирургического подхода для того, чтобы попытаться улучшить прогноз. Спасибо.
Спасибо большое. Со своей стороны я хочу сказать, что наш интерес к детям раннего возраста не ограничивается только набором пациентов, но самое главным является то, что мы начали развивать новое направление. Обращу внимание, что не в педиатрии, а в онкологии, которое мы назвали неонатальная онкология. И только что на бюро Большой академии наук Александр Григорьевич представлял наш опыт большой по лечению данной группы пациентов и те идеи, которые должны быть. На наш взгляд, самым важным компонентом является начало онтогенетической реабилитации с того момента, как ребенку поставлен диагноз, поскольку мы вмешиваемся в развитие ребенка на таких ранних этапах, когда любое промедление в развитии или нарушение последовательности развития является необратимым. Я благодарю вас от всего сердца. Спасибо большое. Очень надеемся, что следующая встреча состоится уже в вашем центре, нашей делегации. Thank you.